All right, looks like we're pretty stable for participants, so why don't we go ahead and get underway. Good afternoon, everybody. For those of you who don't know me, my name is Jessica Mulligan. I'm a professor in the Health Policy and Management Department, and I'd like to welcome you all to our webinar today on COVID-19. I especially want to welcome you on behalf of the Health Policy and Management Department, and also on behalf of my co-hosts, Dr. Deborah Levine and Dr. Tuba Agarton, also of the Health Policy and Management Department. Also want to offer a special welcome to our students. It's lovely to see some of your faces cycling through here. We are definitely missing in-person classes. And really the idea for this came from students. So as many of you know, I teach our regular epidemiology class, and I've been getting quite a few emails these last few days saying, you know, what's going on? Can you help us understand? Or people having specific questions about COVID-19. And so we thought one way to kind of reach out to our HPM community and find out what you guys are thinking and what your questions are is to do a little bit more of an organized response through this webinar. And so that's what we're going to do today. I also want to thank Sarah Watuzik, who is our amazing and talented administrative assistant in the Health Policy and Management Department. She's really provided a lot of technical and graphic design expertise and skills for us. So thank you, Sarah. Before we get started, I have a couple of housekeeping notes. So one is, as you may notice, we are recording this webinar. So our plan is to make this available for students who are not able to attend at this time. So we're planning to post it. So keeping that in mind, it would be helpful if folks who are watching could mute the sound, and also muting the video helps us keep the bandwidth open and makes for a more higher quality recording. So I'd appreciate it if you could do that. We will be taking your questions at the end of the webinar. And so to submit a question, you can use the chat feature on Zoom. So if you can just enable chat, and then when you're typing a question, just make their first word question, and whatever question you have. And Sarah will be aggregating those questions, and we'll have a Q&A session at the end. So it'll be a little bit more interactive. I think that's it for the housekeeping questions, unless Dr. Levine or Agarton have anything else to add? I'm not hearing additions, so I will go ahead and open up our presentation. Okay, awesome. So as you know, today we're going to talk about COVID-19. We're going to try and cover some past, present, and future trends. So I'll be starting off with a kind of epidemiological perspective, giving an overview of the current outbreak and talking a little bit about the modeling around future trends and what we might expect. Then Dr. Levine will take over with some reflections on the history of infectious disease pandemics. And Dr. Agarton will follow talking about the differential global policy response to COVID-19. And then we will wrap up with a Q&A session. So we hope to spend maybe the first 45 minutes to an hour with the presentations, and then leaving about 15 minutes to a half an hour for the Q&A session. Now, one thing we want to make clear is this is a very fluid and evolving situation. So we've really done our best to give you accurate and up-to-date information. Many of my slides I updated this morning with the most recent numbers, but do keep in mind that the date of this webinar is April 1st. And though there will be a recording that you might watch in the future, the information and situations may have changed. Okay, so I'm going to jump right in with an overview and talking a little bit about future trends. So when did this all start? Where did it come from? Well, COVID-19 is a coronavirus. So though COVID-19 is a novel form of this virus, coronaviruses are not unknown to us. In fact, we know them quite well. They're an RNA virus. SARS and MERS are two other examples of coronaviruses. But also there are commonly circulating coronaviruses that are responsible for the common cold. They're not the only virus that produces the common cold, but they're one of them. So humans have had a lot of interaction with coronaviruses. This particular one is a zoonotic virus, so it crossed over from an animal host into human populations. And it's most closely related to a coronavirus that is native to a bat species. So that was its primary host. There was some kind of spillover event that happened. We don't really have all of the details, whether this spillover happened directly through consuming bat as food, or maybe through some kind of intermediate host or indirect. So maybe there was some other animal who consumed bat that then was consumed by humans, and that's how the virus started circulating in a human population. So we're not totally sure, but what we do know, what is abundantly clear at this point, is that it is now firmly rooted in human populations, and there is ongoing human-to-human transmission. So though there was an initial spillover event, there probably has not been continuing spillovers, and what we're really seeing now is human transmission. There have been some rumors that this virus was genetically engineered, and there just is not scientific data to support that rumor. In fact, most of the world's scientists have come together and signed this statement that was published in The Lancet, and many of the world's major scientific organizations have also signed on. That states that COVID-19 has a natural origin. And they know this from analyzing the genomes and from understanding similar coronaviruses. So the first cases of COVID-19 started popping up in Wuhan, China in December of 2019. And what we're looking at here are data from the first 425 confirmed cases of novel coronavirus pneumonia that appeared in Wuhan, China. So these were cases that were severe enough that they caused pneumonia and led to hospitalization. So you can see that some of the cases in the dark orange were linked to the Hunan market. That's that wet market that maybe you've heard about, where seafood and other animals were sold. And then those lighter orange cases are ones that are not linked to the Hunan market. So what this indicates is initially the hypotheses were that that spillover event probably happened at that wet market, but subsequent analysis has led people to think that that's probably not what happened, because if these cases were resulting in hospitalizations at this date, the first transmissions would have been much earlier. And so though that market may have been a site where there was a lot of ongoing transmission, it probably wasn't the initial source of that crossover. But again, that's not completely known at this point. Also should point out here that very quickly, the Chinese CDC implemented public health control protocols. They began to investigate this pneumonia of unknown origin, and were able to isolate the gene sequence, and they shared that gene sequence over here on, I believe it was January 9th of 2020. So very quickly, they began to implement infection control methods and do an outbreak investigation that led to the identification of this novel coronavirus. Here's some additional data from that same study of those first cases of that viral pneumonia. And this is where we get some of our initial information about the incubation period of COVID-19. So when we talk about an incubation period, we're referring to the time between exposure to that virus, so infection by that virus, until the person develops symptoms. So if you look at that square A, you can see that the days from infection to symptom onset varied from about 1 to, at that outer tip of the tail, 21 days. But most people fell in that 1 to 14-day range, and most commonly around 5 days. So if we're wanting to know when somebody might have been infected with the virus and they're showing symptoms, we need to look backwards at least 1 to 14 days in order to identify that possible source of transmission. I also want to draw attention to this square D, where we're looking at days from illness onset to hospitalization. And here you can see that it took quite a while for many of these cases to develop, progress to that severe pneumonia that merited hospitalization. So there's kind of 2 different sets of data here, but they're both averaging around 10 days. With that longer end of the tail going out to 20 and even 30 days between development of symptoms and hospitalization. Keep in mind that that infection event occurred even prior to the onset of symptoms, as we just learned talking about the incubation period. So this helps us understand a little bit more about what's happening right now in the US when we're seeing this dramatic uptick in hospitalizations that we're experiencing really this week. That's giving us information about infections that occurred, anywhere from 10 to 30 days ago. So we're really just now beginning to see things that were happening over the last few weeks in terms of the transmission of the virus. So what are some other things we know about COVID-19? I'm sure you've all heard about the symptoms already, but the main symptoms that your healthcare provider is going to be looking for that are integral to the case definition of COVID-19 are going to be fever, cough, and shortness of breath. Now, the thing that's really tricky about this is it appears that many people who have been infected with the virus may be asymptomatic or only have very mild symptoms, although it is still likely that they are able to spread the virus, so that there's some form of viral shedding, and so they're able to infect others, even though they may be very mild or even have no symptoms. For folks where the symptoms progress, that's when that viral pneumonia tends to develop. So that extreme shortness of breath, that tightness in the chest, extreme difficulty breathing. There's some reports of other symptoms. So there's some GI related symptoms. So maybe diarrhea or other gastrointestinal symptoms. There's some evidence that there may be some links to cardiovascular events, but the main symptoms that we're focused on are fever, cough, shortness of breath, and in those more extreme cases, that pneumonia. Secondary to that, there may be some organ issues, so organ failure, maybe kidneys, are one of the ways that some of these symptoms begin to manifest in those more extreme or more acute cases. Okay, so how infectious is COVID-19? One way we have for measuring this in epidemiology is to look at the basic reproduction number, which sometimes we also call R-naught. The R-naught for COVID-19, and again, this is based on early data. This figure comes from a review study that looked at 12 different studies that have been published. But the estimate is that the R-naught is somewhere between 2 and 3. So in other words, every infected person will likely infect 2 to 3 additional people. To give this some context, this is more than flu, so it's more infectious than flu, but it's less infectious than some of our other common diseases like measles, rubella, and pertussis. The R-naught can also be impacted by behavior like distancing and population factors like underlying health status and age. So how is it transmitted? COVID-19 is transmitted through respiratory droplets. So this is not the same thing as being airborne in the way that measles, for example, can be airborne. COVID-19 needs to be it's in droplets. These tend to be heavier, so they kind of fall out of the air more quickly than an infection that we would consider airborne. However, those droplets persist on surfaces for some time, and so there's evidence accumulating that that's one of the kind of vectors of spread. Now, the virus needs to enter the respiratory system through the mouth or nose and maybe the eyes in order to cause an infection. So this is typically going to happen if you are very close to, so within 6 feet of somebody who is coughing or sneezing and sending those respiratory droplets into the air, or if you come into contact with those droplets on some kind of surface and then you touch your mouth, face, nose, and they can then enter your respiratory system. Again, as I already mentioned, asymptomatic people can shed virus and potentially spread the disease. So what's the case fatality rate of COVID-19? In other words, how serious is the infection that's produced? And like so many things with this, the data are still emerging and we just don't know for sure. But when I'm talking about a case fatality rate, what I'm talking about is the proportion of people who die out of everybody who contracts the disease. So when we're calculating our case fatality rate, we tend to have pretty good data about how many people die from the disease. Our numerator tends to be pretty good when we're dealing with deaths. But with this particular disease, it's new. The tests have just been developed, and in many places, they have not been widely administered. So our denominator, which is all the people in the population who have the disease, is just not really accurate at this point. So many of these, there's a lot of estimates that are out there for case fatality rates. They're kind of all over the place. If you just look at the WHO data that we're going to look at in a moment, we would get 4.8%. Some of the lower ones are like 0.9% in Germany. However, I'll say in Germany, there's been extensive testing. It's one of the places where the tests are being manufactured. And so they're going to have a much bigger denominator than, say, the United States, where we have not done nearly as much testing as they've done somewhere like Germany. The case fatality rate the numbers coming out of Italy are very high, but again, it's hard to know how to interpret these. Partially that's due to there being an older population in Italy and then in some of the other places. And some of our estimates right now give us a case fatality rate of 1.8% in the United States. But again, this is really, I would consider this very preliminary until we do much more widespread testing. So what's happening in the US? Here we're looking at data from the CDC. We've got the cumulative total number of COVID-19 cases in the United States through March 30th. You can see, even though it looks like from January 12th to the beginning of March, there was nothing, there actually were cases those days, but they were so small compared to where we are now, you can't even really see them on this graph. But as you can tell, we're in this phase of rapid ramp up. That's the part of the epidemiologic curve that we're in right now. We're seeing dramatic increases across the United States, and we can expect to see that at least for the next couple of weeks. And of those cases, we've seen 2,860 deaths, and these data were as of March 30th, so that has even increased by today. So who's most at risk? Some of the two major things we've been talking about is age and your underlying health condition. So I'll start with age. Here, these data are from the United States. This is data from the CDC that was published in the MMWR, the Morbidity and Mortality Weekly Report. And this is showing us for cases from February 12th to March 16th, what was the age distribution. And we're specifically looking at of people who were hospitalized. Then within those hospitalizations, the cases that were more serious and were admitted to the ICU, and then deaths. So you can see that every age group experienced hospitalizations. They were, of course, were very few with the 0 to 19 group, but that's only true of that group. Every other group saw significant amounts of hospitalizations. And though, as we get into the older age group, so 60 and above, we are seeing higher death rates. So there is, very clearly COVID-19 is more dangerous as age increases, so risk goes up, but there's nobody for whom there is no risk. As I said, these data only go through March 16th. Since then, there have been deaths of people under 19 years of age. So the other kind of dimension of who's most at risk has to do with underlying conditions. This is also data from the CDC. Here we're looking at data that goes through March 28th. So this is a little more recent than the last slide that I showed you. But here what we're looking at is folks who had underlying health conditions. So and this is only for people for whom they were able to get that data. So this actually excludes a lot of the people who have been diagnosed with COVID-19, but this is sort of a subset of that total group of people who've had COVID-19 for whom we were able to get more robust data where we could look at underlying health conditions. And there's a lot going on here, but I just want to draw your attention to two things. We're going to compare folks who were not hospitalized to people who had an ICU admission, so had kind of that more serious level of hospitalization. And you can see if we look at folks who were diagnosed with COVID-19 but not hospitalized, 73% of them had none of the above chronic health conditions, whereas 27% had one or more underlying health conditions. But then if we go over and look at, well, who's getting admitted to the ICU, those numbers are almost inverse. So in terms of people who are getting admitted to the ICU, 78% had one or more underlying conditions, and 22% had no underlying health condition. So we can see that having an underlying health condition or a chronic health issue is really strongly related to having a more serious experience with COVID-19, resulting in ICU admission and hospitalization. So what are some of those conditions? We're talking about diabetes, chronic lung disease, cardiovascular disease, folks who are immunocompromised or have renal disease, that's kidney disease. Some of the other ones that are prominent are there's a big bucket of other chronic conditions that is included here, as well as people who are former smokers are also at increased risk for having these more acute symptoms. Okay, so what's happening globally? And I'm sorry, I'm taking up too much time, but I just have a couple of more slides before I turn it over. So what's happening globally? These data are from the World Health Organization. We can see that so far there have been a little bit over 750,000 confirmed cases globally, with more than 36,000 deaths. And these data were as of March 31st, so as of yesterday. As you can see, these orange bars are looking at the Western Pacific region. That's telling us the story of that initial outbreak in China. So we can see that those cases were increasing towards the end of January through February. They began to decline at the beginning of March, but now towards the end of March, we're seeing an uptick in cases in the Western Pacific region. And so that is somewhat concerning. So as China has relaxed some of its distancing measures and tried to move back to having some semblance of normality, we're beginning to see a kind of second mode or second peak in the distribution of cases, and there's a concern that they're being reintroduced by folks who have traveled. The other big story here is the the epidemic in Europe has really dominated the cases globally throughout March. Though in the last week or so, the Americas, we're beginning to see massive upticks in cases in the Americas, and that is really being led by what's happening in the United States. So this gives us a sense of what's happening globally, and I know Dr. Agerton will kind of take us back to thinking about some other cases. So when will this all end? I think that's the question everybody wants the answer to. And if I knew that answer, I wouldn't be here today. I would be, at the CDC or the WHO or something. But it's the million-dollar question. And the reason why it's so difficult to answer is because there's so many things it depends on. It depends on how well and for how long we physically distance. So we know that once we begin to relax some of these distancing measures, that we may see a resurgence of cases. It depends on the ability of our healthcare system to cope. So how are we going to deal with our supplies of personal protective equipment and ventilators? There's not currently any approved medication to treat COVID-19, but we know that ventilators work. Ventilators absolutely save lives. And so making sure we have enough of those and those are in place is going to be really crucial. What's the impact going to be on the healthcare workforce? Are we going to be able to sustain our healthcare workforce? And then what about secondary impacts on other medical conditions? So for the longer that things are shut down, where we're delaying routine medical care, we're likely to see an uptick in morbidity and mortality from other conditions that people aren't able to get handled in a timely manner. Also, this all depends on political and economic decisions. So, we can do epidemiologic modeling all day long, but if our leaders decide that other priorities should weigh out, such as getting the economy going or other kinds of political decisions, then that's definitely going to have an impact on what happens with the curves. And then, we're going to have to follow and see when the epidemic curve peaks, and a lot of decisions will be made around that. So once we begin to see that the cases are decreasing, we're likely to see opening up of some of the restrictions that are being placed on us in our daily lives. But that means that, like we just saw in the China data, there's probably going to be multiple peaks in incidence rates and in death rates from COVID-19 as we kind of respond as a society and create policies around how to handle the pandemic. And of course, it depends on the availability of new treatments and a vaccine. Most estimates are saying it's about a year to 18 months until we see a vaccine. And so, we don't want to get ahead of ourselves there. Even with diseases, respiratory infections like the flu, where we have a vaccine, we still see 55,000 or so deaths annually from those diseases. In contrast, the Anthony Fauci and other folks working on the national response to coronavirus last night said that they think that somewhere between 100,000 to 240,000 people are likely to die during this outbreak. So that is significantly more than we see from a flu outbreak. And, in my estimation, these are somewhat optimistic figures. These kind of depend on us actually embracing and sticking with some of the physical distancing and quarantine rules. So where can I get more information about this? We're in a strange situation where we're both like bombarded by information and also don't know some really crucial things about the epidemic. So all I can say is I would stick with those official surveillance data sources. They're not perfect. Our data sources in the US have gotten a little bit politicized, but I keep going to the CDC, keep looking at those morbidity and mortality weekly reports. That's going to give us our official surveillance data. The WHO is a good source of data, especially their daily situation reports. Also look at what your state health department is putting out for your more local, local experiences with the pandemic. There's going to be a lot of variability geographically in terms of the timing and the severity of this epidemic. Also, look at the peer-reviewed journal articles. So the Lancet, the New England Journal of Medicine, JAMA are all good places to go. Good news is that most of the publications are now, things are open access that have to do with COVID-19. So they're not behind paywalls. They're trying to encourage intellectual exchange, and so that people are sharing their results. But the findings right now are kind of all over the place. So keep that in mind as you're making sense of what you're reading in those peer-reviewed journals. It can be a little overwhelming and frustrating, but it's also, that's just kind of how science works, as everybody's out there gathering data in the midst of a pandemic and trying to piece things together. Rule of thumb, beware of that first report of an association. So if somebody says, we found this miracle cure for the first time, or we're really sure this thing is going to work, don't take any action until you've seen, 5, 6, 7, 8 articles that confirm those same findings. So keep in mind those kinds of basic principles of how we make sense of scientific reporting and scientific data. We need these findings to be replicated. And that's why you might want to look for review articles that are doing some of that work of sifting through all of these disparate findings and trying to come to more generalizable conclusions. Lots of great stuff is happening in the media. The New York Times has a great site for COVID-19. Kaiser Health News, if you don't already follow it, you should, as well as statnews.com. And universities are doing a lot of work. The Johns Hopkins in particular has some great resources that are out there. So I've already taken up too much time. I'm going to turn it over now to my colleague, Dr. Levine, who is going to help put this in context and help us maybe learn some lessons from history.
Hi, thank you so much. Jessica, I have not felt so calm hearing all of this in a while. We should have done this. We should do this every day. I'm going to talk for just a little bit of time about some of the lessons that history of our healthcare system here in the United States and our previous experiences with pandemics can bring to bear on our current situation. So if you wouldn't mind, Jessica, the next slide. Great. So one of the things that I always like to keep in mind is that if you live with people, you also live with microbes. And particularly in our cities, for the last 130 years or so, coping with how to picture germs, how to manage and deal with germs is something that we all have to be thinking about. And the New York City Department of Public Health was the first metropolitan department of public health. It was established in the late 19th century to manage the new understanding of germ theory. And the poster in the upper left-hand corner here is actually it's also behind my head, but it's from an exhibit at the Museum of the City of New York that was called Microbes and the Metropolis, the Other New Yorkers. And it was such a brilliant exhibit, and I wanted to start off with it today because it treated the microbes as their own sort of entities within the city that needed to be managed and understood. And then also surveillance and anti-spitting campaigns were some of the first things that were introduced. So the sort of Dixie cup looking thing at the top is a container for stool specimens that every school child would have to bring with them for analysis by the city's health department to test for all kinds of bacteria and microbes. And below the sort of pretty blue container was a kind of a travel spittoon. So one of the first things that happened after people began to understand that germs could facilitate the spread of disease was anti-spitting campaigns. We should probably stop just spitting on the streets of the city. And people would carry around these sort of ornamental and lovely little vessels for carrying that. So I wanted to kind of immerse us first in this idea of what it's like to live in a city that has to think about managing the spread of germs in very real ways, kind of all the time. And of course, germs have never gone away. As Dr. Mulligan pointed out, we have influenza every year and all of those things, but the last few decades have really been about a focus on chronic illness and non-communicable illnesses within our American cities. And what I'm noticing is a real return to concern about acute and communicable diseases, particularly around the COVID-19. So, Jessica, can I have the next slide? Oh,
sorry.
Okay, I didn't realize that my notes would come up quite like that. Okay, so those were my notes, but I just said them out loud. So another thing to keep in mind. So our microbes are with us. We're managing them all the time. One of the things that is central to the public health is effective messaging. And I've included for you here at the bottom a selection of posters from the past about polio, about tuberculosis, about influenza, about sexually transmitted infections, all of which were designed to educate the public and sort of convince them, right? Bring them into the public trust and say, this is what you should do to avoid polio. This is what you should do if there's influenza in your community. And trying to bring them in. So there's been a lot of interesting graphic design, health communications messaging over the years. And one of the things that I think is a really interesting area of study is sort of what messages are effective and what messages work. I'm just going to call your attention before we go to the next slide to the bottom left-hand image, which is a poster that would be put in Chicago during the 1918 flu pandemic. Now that's a flu pandemic you've probably been hearing about quite a bit over the last few weeks. It's the last big influenza pandemic that we have had here in the United States, and its centennial was just a couple of years ago. So the influenza pandemic, that's a poster in the corner that would be placed in Chicago on places where influenza had been identified. So keep that in mind, and let's go to the next slide. Because the next thing I want to talk about is this idea of social distancing. And that's why we're all doing this from our homes right now. That's why all the conversations about flattening the curve and all of the things that you have been probably really living with are happening. And social distancing is not a new idea. It saved thousands of American lives during the last great US pandemic, the influenza pandemic of 1918 and 1919. Back then, many cities such as Philadelphia and Boston were hesitant to issue stay-at-home orders. They didn't want to upset their local economies. They didn't want to risk people's jobs. And cities, especially Philadelphia and Boston, waited as long as they could before issuing social distancing orders. Others, such as St. Louis and Chicago, were more proactive, and they issued strict stay-at-home orders earlier on. And what you can find, and this is a study that was done for the centennial of so in 2018, and it was published in JAMA, is that the cities that instituted social distancing measures quickly, they suffered both less economic consequences as well as fewer deaths. And that's because the sooner they got the social distancing in place, the quicker and more mild the illness was in their city, the more they were able to get back to business sooner and with more full workforces. So if I could have the next slide. So the example of this that I want to spend a minute with is the infamous Liberty Loans Parade. And what you're looking at right now, sort of that top picture, is more than 200,000 Philadelphians gathered for a celebration of the end of World War I. Despite the warnings, Philadelphia would not cancel its big event. Instead, on September 28th, they threw a World War I parade that gave thousands of onlookers the flu. More than 200,000 spectators flocked to the parade on Broad Street, which is a main downtown thoroughfare in Philadelphia. Within 72 hours of the parade, every bed in Philadelphia's 31 hospitals was filled. In the week ending October 5th, more than 2,600 people in Philadelphia had died from the flu or from its complications. And a week later, that number rose to more than 4,500. So that top image is the image of the parade itself, which was both a fundraiser for war bonds and a celebration of the end of World War I. The image below is Red Cross volunteers trying to sew masks for protective equipment which was in short supply in 1918 for healthcare workers and other volunteers. And the final thing is a graph indicating, the way that the spike of the cases and hospitalizations affected the death rate. Sorry, I have two elephants outside the office that I'm in. They must be elephants. They can't be young boys. Okay, could I have the next slide? Great. So in this same study from JAMA for the centennial of the 1918 flu, they provided data for a number of cities. The top line in that graph is cities that ordered social distancing measures later and for shorter periods. And they had higher spikes in death and higher overall death rates. And that includes my hometown of Pittsburgh, that includes Boston and San Francisco, and the nearby to Providence, Fall River, Massachusetts. The cities that ordered social distancing measures sooner and for longer periods slowed infections and lowered overall death rates. And you can see the examples on the bottom line there: Louisville, St. Louis, Indianapolis, and Minneapolis. Can I have the next slide, please? Great. So if you're interested in the 1918 flu pandemic and you'd like to read more, there is a lot of good public history coming out right now on what was called then Spanish flu. And by the way, it was not called Spanish flu because it originated in Spain. It was called Spanish flu because the Spanish press was the only press that would allow people to report on the death rates in the beginning of the pandemic. We actually think the Spanish flu originated in Kansas here in the United States. But the press did not permit, and politicians and the press did not permit publishing about it. And so it got sort of hit with that Spanish flu moniker. But here's just a couple of links, and you'll be able to click on these to some of the things I've been talking about, and a nice short video about the 1918 flu pandemic that was aired a few years ago on CBS Sunday Morning News. Can I have the next slide, please? Great. So the next thing I want to talk about is scientific research and the public trust. And I want to take us back in time, not quite so far as the 1918 flu pandemic, but to the 1940s and 1950s, when polio epidemics were, and polio outbreaks were still very common in the United States. And in fact, nearly every summer throughout the 1940s, there were polio outbreaks which caused deaths, infantile paralysis, and a number of other devastating things. Now, there was a therapeutic intervention developed in the 1940s called the iron lung, which is a forerunner to respirators and ventilator technology. Today, here I am posing with one of the original iron lung machines. Can't resist showing you my vacation photography, and some photos of what that looked like. But as you can see, these were they were life-saving and life-sustaining technologies, but you had to spend virtually your entire life encased in one of these sort of canisters in order to support the breathing until either you got better on your own or you remained in that chronic state. In the course of researching this, I actually learned that the first ever successful iron lung treatment was done at Providence College on Lower Campus in Howley Hall to save the life of a Dominican priest who had polio in the early 1950s. So that's a whole other research project that we're going to have to take up, but what a PC connection. Can I have the next slide? But the real reason I bring up polio is because polio is an example of just how central the public trust is to managing these epidemics and public health problems. Polio was a deadly virus that affected many. Private, public, and philanthropic money were all marshaled to fund research for a vaccine and for effective therapeutics. Jonas Salk was the investigator whose team eventually created an effective polio vaccine, and the public in turn was willing to act as a test subject and willing to vaccinate their own children when effective vaccines were developed. So the polio pioneers, which you'll see on this and also on the next slide, were 2 million American public school children whose parents had signed them up to be in a randomized clinical trial to test for to test the efficacy of the polio vaccine. And I pointed out because imagine trying to convince 2 million kids and their families and their parents to participate. You know, the disease itself was so threatening and was so much in the forefront of people's experiences that they were really trying to be extremely good citizens, as well as willing to take on some risk to potentially ameliorate these problems. And ultimately, when the effective vaccine was developed, if I could have the next slide, when the effective vaccine was developed, that vaccine was determined that it was never patented, it wasn't sold, and it was made free for all. And so these are some more pictures of school kids, public school students in the 1950s who participated in those trials. And then the next slide is I think it's the New York Times on the day that the Salk polio vaccine was announced to be successful and safe, and that free vaccines would be given in public schools starting very soon, starting April 25th, starting the next week or two. Finally, before I turn things over to Tuba, I wanted to talk a minute about public health and civil rights. So the question that Americans ask over and over again during debates about the public health is, when, if ever, is it appropriate to limit the freedom of the individual, however temporarily, to protect the health of the public? This is something that speaks, I think, to our individualistic political culture. It is something that pops up again and again. We see it, you know, I've talked about this in HPM 101, so some of you who took that with me might remember, you know, everything from should we be listing calories on menus, to how big of sodas should you be allowed to buy at Madison Square Garden. All of those questions tend to get framed as, what is the balance between the freedom of the individual to buy the biggest soda they want and the health of the public? And in the case of infectious data, in the case of infectious disease, this becomes thrown into very sharp relief. If you accept, as data shows that nearly all Americans do, that there is some point where it might be necessary, however temporarily, to protect the health of the public by limiting the free movement of certain individuals, where do you draw that line? And one of the key examples in American history that I think about, and I've been thinking about a lot lately, is Mary Mallon, who was an Irish immigrant and domestic worker. She became known as Typhoid Mary, and she was the first documented American asymptomatic carrier of an infectious disease. She was an asymptomatic carrier of typhoid, and she was able to pass the disease on to other people, even though she herself either had a very mild version, didn't know she had typhoid, or never showed symptoms of the disease. And Mallon was held in quarantine on an island off of Manhattan for more than 3 decades, and is a very, I think, useful case study of the ways that things like class and immigration status and scientific knowledge can sometimes intersect in the ways that the public chooses to make these decisions around individual freedoms and the public health. So those are my kind of historical, oh, that's fine. Those are my kind of like thoughts, historical guiding points I want to kind of keep in mind as I sift through some of that. And now I'll turn it over to Dr. Argerton for the rest.
Dr. Tuba, would you like me to stop sharing so you can take the slides?
That would be great. Thank you. So I think it won't let me do it. Unfortunately, Dr. Mulligan, I need you to do it still. Oh, there we go. All right. I think. Okay, share screen. Great, thank you. So hi, I'm Dr. Tuba Artan. I am a professor here in Health Policy and Management program in Providence College, and I work on medical sociology, global health, and comparative health policy. So I wanted to start today to discuss the value of comparative analysis. I really have two main goals. So the first one, or objectives, the first one is to examine with you how we discuss experience of other countries. And the second one is to critically assess what kind of learning we do. And what we do with that information. So are we just doing information gathering? Or are we looking for some kind of inspiration? Or is it policy transfer or emulating the others? These are all different things actually that I'd like to discuss with you today. So I'd like to start with a question, like when was the last time you heard so much about other countries, about China, about Italy, about South Korea? So when was the last time that had ever happened? So it's a lot, right? Currently, the type of information that we're getting. So I have pulled out a number of examples to walk you through these two questions really, and with a sort of critical analysis and take home points. So this one is from Harvard Business Review. It's a recent publication on lessons from Italy. So I'd just like to highlight a few things in this quote. So it starts with saying, as policymakers around the world struggle to combat the rapidly escalating COVID-19 pandemic, they find themselves in uncharted territory. And it talks about China, South Korea, Singapore, as you can see, a number of countries. Then it makes an assessment about United States and Europe. Then it continues. However, they are repeating many of the errors made early on in Italy, where the pandemic has turned into a disaster. So please pay attention to the way we describe the epidemic too. So here is a way of talking about it in terms of a disaster. And I'd like to come back to this description later. And then the purpose of this article, the authors explain, is to help US and European policymakers at all levels learn from Italy's mistakes so they can recognize and address the unprecedented challenges presented by the rapidly expanding crisis. Can I get the second one, next one? So this is another illustration of the comparative analysis. This is the Johns Hopkins website Dr. Mulligan was talking about earlier. The reason why I wanted to show you this is not about the accuracy. I've heard some discussion about that, but it's more about the way it presents the information. So on one side, you see the number of cases, the confirmed cases, and they're all listed in terms of countries, so you can compare them. And then you see on the other side the number of deaths and the number of recovered, and in the middle is the world, right? The map of the earth, where you see all of these red dots, giving us the impression that it is a global pandemic. Next slide, please. So this is the image from the South Korean context. If you can click, a image will appear, yeah. So this is another example I wanted to highlight. This is a story from New York Times, published March 23rd. And again, I'd like to highlight a few things. So first of all, the policymakers apparently are communicating. And anyone who studied comparative health policy and global social policy, we always pay attention to this communication among policymakers and the networks and academics, because that's kind of how lots of ideas are shared and transmitted. So that's kind of part of the policy debate. So this is one of the examples of that. But in addition, there is more that I'd like to highlight. So if you look at the second sentence, some have begun to show interest in emulating its methods, but only after the epidemic had accelerated to the point that they may not be able to control it anytime soon. So I'd like to highlight the word emulate there, and want you to now sort of in a few minutes, I'll give you more information about what South Korea did. And I really want you to think about this second thing. So the first one, as I was mentioning earlier, is about information gathering. The second one is what you do with that, right? So in this example, we are talking about emulating or imitating what they're doing, or in other words, policy transfer. Next slide, please. So this, I wanted to use this one also because, first of all, it talks about what Africa might teach the world. So lesson drawing is again a big part of this. And the second point I'd like to make is the comparison among diseases. So we just heard Dr. Levine talk about the Spanish flu. And in this example, we're talking about Ebola. So this has also been a common theme in terms of seeing how we can learn from other infectious diseases. Next slide, please. So what do we compare? We compare the trajectories, number one. So if we can get the whole slide. The trajectories of the disease, the transmission models. We learn about the problem definitions and specific policy tools. We can learn about ideologies, justifications, norms, attitudes. We can learn negative lessons, not only positive, right? Emulation is positive. And we can also learn about relationship systems, policy process. So if in the next slide, you will see that it's about the transmission models. So the next image will show you the three control models. This image is from this is from Hong Kong, from a research center. And what they studied is the trajectory of the disease. And they talk about the early control models, the midterm control models, and the late control models. And the next slide will show you the trajectory. And this is a very typical view of the comparative framing, in the sense that you put yourself in relation to the others. If you can click the next image, it will show us the, yep. So they arrived at this image by looking at quarantine controls, public sentiment and trust, population density, medical resources, healthcare system, and size or percentage of the elderly population. And what it's trying to do is to show us the stages of the epidemic. Remember, this is a common enemy, right? And in terms of this enemy, where are we, how are we doing? So that's one way of framing this, or trying to understand where we are in this process. So this is a very typical use of comparative studies. Next slide, please. So the problem definitions. And I wanted you to remember the use of the word disaster in the first example from Italy. So let's say you are part of the American government and your population is not paying much attention to the epidemic and you want them to take it seriously. So what you can do is you can use Italy as an example and talk about the disaster there and make sure that the problem definition as a disaster sticks, right? So it's a very purposeful use of certain countries as we call it in policy literature, as ammunition. So this is not a positive or negative assessment, but it's about framing, right? How governments frame these things and what they do with the information that they learn. So the second way is the second thing we learn is the specific policies and tools and how they are packaged with others. And the final one is the timing of policies. So what did they do first? How did they go about this? The trajectory one is related to that, but you can also learn about how to space or time your policies. So one example, Dr. Mulligan, if you can click one more. So the herd immunity policy, for example, in Britain versus the strict containment measures in Wuhan. So you see that comparison between different kinds of intervention, but they also involve very specific mix of different kinds of policy tools. So that's very important to compare, to learn about, and maybe tailor to your own country, depending on your priorities and your policymakers. Next slide, please. For this last one is from the article on Italy. Italian leaders did not perceive the magnitude of the threat posed by COVID-19 in a timely manner. So this is also another kind of using negative lessons, right? A warning. So you can, if you're the news sort of the journalist, or if you're the researcher, you can try to make the policymaker pay attention to certain kinds of issues, and this could be one of the ways you can do it. Next one, please. So this is an image. Images have been very powerful during this pandemic. So that's the first one is from Italy, hospitals being overwhelmed. And the second one is going to be about Spain. So this is a very difficult one with coffins listed, put next to each other. Next one, please. I put this for you to see the packages. So this shows both the timing of Chinese policymakers' decisions, but also how they have packaged different kinds of policy tools, such as the school closures or the extension of the Spring Festival holiday, among other measures such as closing the seafood market and things like that. Next one, please. I'd like to go back to South Korea for a minute, because I really would like to highlight the point about the specific tools. So if you can click on the New York Times article. So South Korea, this is a very specific tool example, develop policy tools and practices for aggressive contact tracing during the MERS outbreak. Again, you see the comparison with another outbreak. Health officials would retrace patients' movements using security camera footage, credit card records, even GPS data from their cars and cell phones. Dr. Ki, a key epidemiologist in South Korean response, said, "We are like police detectives." And later, we had laws revised to prioritize social security over individual privacy at times of infectious disease crisis. So this is a good point to pause for a minute, and again to remember the earlier point that I was making. So we can learn arguments, ideas, tools, policy framings, but what do we do with that? So if you remember the earlier emulating argument, I'd like to ask you if US can emulate this. If US population, the next slide will also give us one more example, if US population will be able to do this. The reason why I'd like to bring this is because of the relationships differ among countries, and you already know this. So public sentiment, trust in institutions differ across countries, US versus Netherlands versus Sweden, and also the state's private sector relationship changes, matters from country to country. So the next quote is from Sweden. The Prime Minister, in one of his rare sort of speeches to the population, said, "There will be a few decisive moments in life when you must make sacrifices, not only for your own sake, but also for those around you. for your fellow humans, and for your country. That moment is now. So this is a very typical example of talking to the norms of your own community. And one thing I should mention here is that Sweden did not enforce strict regulations. The restaurants are still open there. So most of the schools are closed, but they have this mid sort of level policy intervention in Sweden. And the way the Swedish government has been justifying it is because our population is very solidaristic and cohesive, and they trust the government, and they will protect each other by voluntarily obeying these recommendations. The next one is from South Korea. I would really like you to see the contrast among countries. So again, the same top sentence highlights their communication practices, but the last one I'd like to read, the last paragraph. The messaging instills a new wartime sense of common purpose. Polls show majority approval for the government's efforts, with confidence high, panic low, scant hoarding. So South Korean populations, it sounds like, have responded quite positively to these very strict or very interesting policy tools, such as using GPS data to trace your movement. Again, I'd like to ask you, do you think this could be emulated? So if you're talking about policy transfer, the second version that I've been talking about, is it possible to do that at all among countries? Next slide, please. So the last and final one is the healthcare systems. So in this epidemic, one of the major differences we see is the structure of healthcare systems and adequate resources that are associated with mortality rates. So this includes the PPE and other equipment. But usually many countries don't talk about insurance. We have to talk about insurance because US is the only country, developed country with no universal health insurance coverage. You can learn other things, such as the proper method of testing, treatment, when you do those things. And finally, you can learn about the organization of the healthcare systems. What's the role of primary care in this epidemic? What about community health centers? What about the organization in terms of the integrated care? For example, what happens to nursing home residents who are discharged from the hospital after they recover from COVID-19? Some nursing homes may not want to take them back because, as Dr. Mulligan explained, we don't know when the transmission exactly stops. And what about the homeless, right? So the structure, the institutions, the way healthcare system is integrated with the rest of social care mechanisms will matter a lot in terms of the response to this epidemic. But again, to ask the question, what are you doing with this information? Are you learning about these and then tailoring them? Or are you sort of trying to emulate them? Next slide, please. So this one will show you two different examples from learning from other diseases. The first one will show you if we can get the boxes in. Yep. So this is from the Ebola article. This one and the next one will have these process, if you will, lessons, just like the last example showed us in terms of what you can learn about the process. So for example, from Ebola in Africa, some of the countries were able to pay attention to local population and what they cared about. And they were very innovative, actually, these local communities. And rather than from a top-down kind of policy making, they worked with the community to develop solutions together. The second one is a good example of a specific policy tool, which is opening community care centers close to where active transmission was taking place. And this was done, again, with the community together. So this is a good learning example in terms of learning about processes. Next one, please. So can you really, one more? So this is the South Korea versus Italy examples that I've been raising for a while. So this is a summary from the articles, news stories. If you look through this now that we discussed these 4 different ways of things that we learn about when we do this kind of comparative study, is you can learn about specific tools, you can learn about processes, you can learn about their cultural values, norms, ideologies. And I do like these 2 examples because they are more about the process rather than telling them you should exactly do this. Next one, please. So the takeaway points is, number 1, when you talk about other countries, please do not think that it's a technical process. This is a truly political process in the sense that, first of all, we may not be presenting the information in an unbiased manner. So often we provide selective assessment of what we see in other countries. So politicians can be doing this, newspapers can be doing this. So I really would like you to pay attention to the selective nature of the evidence that could be presented to you. A good comparative analysis would tell you what they're comparing and what's the conclusions and what they're leaving out, but that's not always the case in these types of stories that we see in the media. Factual errors will definitely be there, so always look for more evidence as you try to understand these other countries and their experiences. We always interpret them, so don't think that you have these facts, but there's an interpretive process there and a major framing. And finally, the circumstances under which learning happens matter a lot. And my final takeaway points in the next slide we'll go back to the very first point that I was making. What is transplanting versus what translating? So this is about the question of what you do with the information you learn from other countries. As a policymaker, as a researcher, as a student, as a sort of informed member of the public, what do you do with that information? If it's about understanding and getting inspiration, great. The more we know, the better options we have, and we can come up with better solutions. But the key point here is that you have to understand that these ideas come from a context, and the circumstances in which these ideas develop need to be understood very clearly. And the other one is what you do with this. So as the first, one of the first examples was talking about, emulating is very tricky. And when policies cross boundaries, we think they change, they evolve. So that's why they never travel intact or unaltered. So therefore, there's always room for translation, and it's important to pay attention to that. I'll stop there. Thank you so much for your attention.
Okay, so I think at this point we can turn it over to Sarah, who has been monitoring the questions, if those are coming through on chat, and we can, maybe I'll come out of the PowerPoint and we can look at people's faces again and answer those questions.
I have not gotten any questions yet, so feel free to put in the chat any questions you have about the presentation. Okay, so we got the first one. Question: is it true that the peak for the US is predicted to come in the second week of April?
So there's lots of predictions. I'm sure that some people have predicted that. It's not really clear if that will happen, if we follow the trajectory that we've seen in other places. So maybe I'm treading on difficult ground here after Dr. Tuba has told us the problems with just translating lessons from other contexts. But if we do follow a similar pattern to what we've seen in other places, I think we can expect within the next few weeks that we'll begin to get to that peak. But again, there's so, as I talked about earlier, there's so many variables at work here. In terms of, are we going to maintain the social distancing? What's going to happen? The US is a really big country, so the way things are playing out in certain cities and certain states first, and then it's likely going to impact other regions later. It may be a little bit more prolonged in the US than maybe we've seen in some other places where they've sort of clamped down more tightly from the beginning. But it's a really difficult question to answer. I'm sure there's modeling that predicts that. I think, more realistically, it's probably going to be like over 4 or 6 weeks that we see that peaking happen. But I don't know if other folks want to weigh in on that.
I think what I'll add is the trajectory, I think, is one of the good ways of using comparative data. So what you said, I fully agree in terms of the different factors that go into it. But I think that kind of comparative analysis in terms of trajectories help countries to plan things and maybe take this more seriously.
Okay, we have a second question. So once the peak does happen, when will social distancing stop?
That's a great question. And I hate to do this again, but I think the answer is it depends. And I think it partially depends on where that peak is at and where our health system capacity is at when that happens. So what we're trying to what we're working with here, or the reason why we're trying to kind of manage the curve the way that we are, is to make sure that the health system is able to respond to the needs of, folks who are getting acutely ill. And so if we peak where we have, people being turned away from ventilators, and it takes us 3 or 4 weeks to get to a point where the health system can even grapple with the demand, then I think we'll see a much slower ramping down of those social, of that physical distancing and those kinds of quarantine rules. So I think partially it depends on how high our peak is going to be and to what extent our health system is able to respond effectively. And so I think those are the things that are playing out. But I think, once we start to see a decrease in incidence, a decrease in deaths, I think we can expect a relaxing of some of the rules. There's some talk now of maybe trying to relax according to risk. So thinking about, if folks have already been infected and have recovered, maybe those are the folks who can return to work and return to a more normal life first, whereas people who are still susceptible hosts, which means that you haven't had the infection, you don't show that you've had any antibodies to the infection, you may want to maintain that quarantine and physical distancing longer. So I think once we pass the peak and we begin to see some relaxing, that it will probably be staged and tiered, and there will probably be some consideration of risk status worked into that.
This is sort of a biological question, but why do the symptoms affect people so drastically? Each day in the news, it seems that there are new symptoms. The other day, I saw loss of smell as a symptom. Do we actually know what this are? Do we know less about than we think?
So there's kind of a lot in that question. I also saw a lot about smell as being a symptom, or lacking taste. There's some reasons why that might be, right? If it's a viral infection of your upper respiratory tract, if we know that sort of smelling is involved in taste, it's sort of logical. It makes sense that could be related. But I think at that point, I think at this point, that's still very much sort of anecdotal evidence, and I'd like to see more robust studies and multiple studies that would actually be able to validate that as a symptom. And I think it'll be a while before we see that for sure. So, I think part of what's interesting about this particular virus is for some people, it doesn't progress to those very severe symptoms, and for others, it does. And I think that's part of the mystery right now, is trying to understand why it can escalate and escalate really quickly for some folks into very severe pneumonia and respiratory issues. And as I mentioned earlier, a lot of the thinking is that that's probably related to underlying health issues and other risk factors like age. But these are, again, really good questions that we're going to be able to answer much more fully in 6 months to a year.
Okay. In the presentation, it was mentioned that there will be several peaks of COVID-19. What does this mean for PC going forward? Would this affect the fall 2020 semester?
Before we get to that, could I just add something to Jessica's excellent answer of Tara's question? And can you see and hear me? Okay, great, thanks. I just want to say that also speaks to the moment that we're in, right in the middle of this pandemic. And I think, as Jessica mentioned in her presentation, and as Tuba mentioned, this is sort of how science works. There's lots of reports. It seems like there's a relationship to loss of smell. We're starting to see it add up more and more. And, I'm reminded of the early days of the AIDS epidemic, and also to go back to the polio epidemic. I mean, people in the United States in the 1950s thought that polio had to do with dirt in your house, and if you just swept up all the dirt, you would really help protect from the infection. It turns out that those are about the cultural values and certain classist ideas and ideas about people who live in poverty that are held by many Americans, and they did not have anything to do with the scientific spread of the disease. So I think that, we're in this moment right now where we're starting to hear all this information. Some of it will turn out to be really good information. Some of it will be conjecture and observation that doesn't pan out in the end. And so I keep saying this is all going to be super interesting when it stops being so scary. And I think that holds for the answer to Tara's question. Does anyone want to take
the one about what's going to happen with PC in the fall?
Sure. I mean, I guess the answer is we are not getting any more information at this point than you all are. In fact, the central administration is sending you the messages, students, first before the faculty gets them, and then they forward us and say, this is what we just sent out to the students, here's the information. So currently the plan is to be back in person in the fall for classes. And I have not heard any discussions about otherwise. I know that the summer school classes are likely to be, especially in the early part of the summer, are likely to be online, but we're really not sure. One of the things I'm noticing is that PC has been following the lead of some of the other larger colleges and universities around. And so there's like a little bit of a week or two lag in terms of our policies and development versus others. So if you're starting to see what other schools are saying, when they start making announcements about fall, it might be a time to really pay attention. But I think for right now, it's too early. We're not sure how well these measures, these physical distancing measures we're taking are going to work. We're not sure what the burden on the healthcare system is going to be, especially in the major population centers where we have a lot of students and faculty. And then I guess finally, there is some conjecture that we could get a little bit of a reprieve during the summer, and maybe even if those cases crop up again in the fall, so following like an influenza year. We don't know if COVID-19 follows that yet, and so that'll be a factor as well.
Okay, another question. I understand that the news is trying to be as transparent as possible while not scaring the public. Do you have any other further advice as to what we should be doing and what we are not already doing to help us prepare for what is next?
I mean, I think we're trying to do most of the things that we need to do right now. So I think staying at home, staying calm, minimizing your contacts with others, not traveling, trying to make sure that your household's basic needs are getting met. So, do folks have enough food in the house? Is there enough money to be able to pay the bills and keep households going? Are all kinds of the first step of basic things to cover. Then there's also ways that we can help our community. This is one of those instances where staying at home is actually helping your community, right? So following these directions and not going out is what's going to protect your neighbors, your grandparents, your friends, all of those folks. But there are, other things that we can do. We can try and support our neighbors, our local systems. We can maybe support with food, with checking in and finding out what people's needs are. And when I say checking in, I mean checking in virtually, trying to connect with more local efforts. For students, I think trying to stay calm, trying to have some trust in the system. There's a lot of us working to try and make sure that your experience stays as smooth as it possibly can, and where there's a lot of people working really hard trying to make sure that you are able to finish out the semester, still meeting some those learning goals that we have for you, but also just trying to be full people and trying to stay as healthy and as sane as we can in these very challenging times. So things that you can do, beyond the messages you've heard a million times about washing your hands and cleaning surfaces and all of that. But think about how you can take care of yourself. Maybe for you that means building a routine. Maybe for you that means letting go of some things and trying to work on kind of accepting the place that we're at right now. I think the degree to which we can all sort of embrace this new reality and try and help one another and stay as healthy as possible during this will really go a long way. Not sure if that answers the question, but those are the things that occur to me.
I think those are great recommendations, Dr. Mulligan. I think what I'll add to that is, so we still are behind testing in comparison to some other countries. And I really, I know the different countries are doing different things about this, but following World Health Organization's advice, I think massive testing, even for asymptomatic people, is very important to understand where we are in the pandemic as a country. So one of the things is, for example, a number of things Dr. Mulligan mentioned, and you have been asking, is does reinfections happen? We don't know. There are a few cases like that from China, but we need the regular testing to be able to see if a positive turns to negative, and then does it turn to positive? What does that mean in terms of viral load and all of these things? Ebola taught us a lot about this. And one thing is, yes, we need time and we need perspective to study these and cases, but at the same time, I think we're falling behind in terms of not being able to test a lot in the United States. Another thing about it is, what is immunity? Do people get immunity? And if they do we get to a point of herd immunity without the vaccines? So that will be good news if we can get there, but I have no idea. So there are tools in epidemiology and in public health to predict these things, but for that you need data, and without testing you don't have data. So a number of public health professionals and faculty members have been pushing for testing, and I'll say I am one of them. Mm-hmm. And the other thing is, I would watch out and read World Health Organization's announcements, as again Dr. Mulligan was saying, because they talk about the trends, right? So this is an infectious disease that's novel, that's new, but humans and researchers and public health has a lot of experience with infectious diseases. So we've studied them for a very, very long time. So they have certain patterns, and as we were talking about, we can learn from other diseases. So therefore it tells us that there's a pattern, and I think World Health Organization has been conveying this pattern as quickly as they learn. patterns help me a lot. When I see the trends, when somebody tells me this is next, I feel a lot better. So those will be the two things I think I would say.
I would love to add on to your point about testing. Testing is so important for all of the reasons that you just mentioned, but also because, it gives us that basic data that we need, but it's also really essential as a public health tool to be able to intervene in the spread. So we can't do effective contact tracing unless we have testing. We can't evaluate if our interventions are working unless we have widespread testing. And we also need it so that we can understand the extent of asymptomatic spread, which right now we just really don't have a handle on. So I think anything we can do to get more testing happening is really important. I think some people just sort of throw their hands up like, well, why do we need a test? Like either you have it or you don't have it, the treatment is the same, but you need it from a public health standpoint if you want to be able to understand and monitor the epidemic and know if the interventions that you're making are effective.
I would also say that testing is really important for, I would also say that testing is really important for research after the fact. Mm-hmm. So for example, we had one of my classmates' moms tested positive for COVID-19, and she got a paper from the Rhode Island Department of Health that indicated that she had been tested and the test was positive. And now she's enrolling in serological studies and other studies that you can only do if you've been tested and are found to have had the virus. So not only is testing important for all of the reasons that you both have been saying, but also because if we want to advance research, if we want to come up with therapeutics or vaccines or understand the disease better, we're going to need definitive answers about who had this so that we can ask them to participate in research studies.
I have one more question here. Do we know if mosquitoes or other bugs can transmit this disease from person to person?
My understanding is no, that they cannot. And this is I think this is an FAQ that's handled on the WHO website. If you go to the WHO website, they have a Mythbusters section that's really good. I spent some time on it yesterday and I was like, wow, I didn't even know that rumor was circulating. But it spreads through respiratory droplets. And so it's not a blood-borne pathogen the way that something would have to be transmitted by mosquitoes. And so, yes, that would be my answer. There's also not good evidence that it passes through the fecal-oral route, in case anybody was wondering about that. So there is some evidence that there's viral shedding in fecal matter, but that it can't not being transmitted through your gastrointestinal system. So in other words, eating, let's say you have takeout that was delivered by somebody who sneezed on it and you ingest it, that virus is probably going to get killed off in your stomach and not going to make it into your respiratory system. So the virus needs to be introduced into your respiratory system, so through your nose or your mouth, maybe your eyes. The evidence is not 100% on that in order for an infection to occur. Have we exhausted our questions?
Yes, no more questions unless anybody else wants to write in the chat.
Okay, well then maybe we will wrap it up there. I don't know if any of my co-hosts have any final words, but it was so lovely to share this afternoon with you all, that we're ending with still 35 participants. So thank you to all those of you who hung in there to the end. Hopefully we were able to address some of your questions, and yeah, I really enjoyed this. Did you all want to say anything?
Yeah, thank you so much. This has been really fun, and I hope it has been helpful.
I'm typing messages in the chat But yeah, I agree. Thank you, Jessica, for having this idea. Thank you, Sarah, for organizing this. Thank you, students, and Jessica for organizing, and everyone. Thank you, students who came. It was nice to see your names and some of your faces flying across the screen. We miss you. We hope you're taking good care. We are available if we are your professors right now, and we can help you to succeed in your completing your online learning or any aspect of your classes. Please reach out to your professors. I'm the chair of HPM right now, and if you want to reach out to me about any of your HPM classes, I'm here. We really want to support you through the rest of the semester and also through all of this. That's it.
All right. Thank you, everybody.
Thank you.
Thank you.